Good evening to everyone. I welcome all of you for our, on behalf of Association for Veterinary Dermatology, India, and Intas Pharmaceutical. I welcome all of you for our dermatology webinar. This particular association we have started with the intention to spread the knowledge of veterinary dermatology for our fellow vets, so that they can do the good practice and they can adopt their standard to the international level, and they can improve their standard like that. Apart from that, our aim is to create interest to the practitioners. So the interest and involvement in identifying the cases and to improve the quality of life for the dog and the cat are very important. So in that we thought we can even involve our practicing vets who are really interested to have contribution in the dermatology. They can also give some webinar on it. So this is the first time we are getting one interested person. That is Dr. Madhavi. You all know well about her. Many of you know her. She is from Pune, and Petwell Clinic is her clinic, and that she is having extraordinary interest to learn dermatology. I know her personally, so it is very appreciating work she has done. So I thought we can also involve such people to give some few lectures, so that you can have a better interaction, so that we will be having a good clinical observation and how people are doing coming forward to interact or contribute to the dermatology science. So I also welcome Dr. Nitin Bhatia and Dr. Amanjot Singh and Speaker Madhavi for the show. And I request Dr. Nitin Bhatia to introduce her.
Thank you, sir. Dr. Nagaraj has made my job very easy. I welcome Dr. Madhavi Awale, the owner of Pet Wellness Clinic at Pimpli, Pune. Dr. Madhavi is a graduate from Mumbai Veterinary College and a postgraduate from Gujarat. She has completed her advanced certificate in small animal dermatology from the European School of Advanced Veterinary Sciences, Australia in 2018 and 19, and also Indonesia in 2020. She is a certificate owner of International E-Learning's Veterinary School, and she is also a full-time member of Asian Society of Veterinary Dermatology. As Dr. Nagaraj said, we have yet another field vet, a practicing vet, who is going to share her experiences on canine dermatology. So over to Dr. Madhavi for an interesting insight into canine pododermatitis, diagnostic and management in companion animals, and the bark of a dog has made it still more interesting that we are going to listen much more from her. So over to Dr. Madhavi for an interesting session on pododermatitis. Dr. Madhavi, the stage is all yours.
Thank you so much. Yes, she has to start my lecture with a bark. She wanted to introduce herself. So she's Brownie. She's my kid in the house. All right. Hello, everyone. And today I'm going to talk about pododermatitis. I'm practicing, and I'll be sharing my experience, as well as I'll be sharing some photographs from the clinic itself. So today I'm going to talk about diagnostic and managemental approaches for canine pododermatitis. Now, what is pododermatitis? It is an inflammatory skin disease of paws. Now, paws means not necessarily it has to be the paws. It can be paw pads. It can be interdigital. And how that is associated when we are diagnosing pododermatitis, I'll be going through that also. It's a very common problem that we see on a day-to-day life in our clinic. And it may involve just one paw. Sometimes you can see that two paws are affected or multiple paws. The four paws may be affected with that. And why this topic needs to be discussed, because it is a very frustrating, it's very frustrating to diagnose it, because it's not just a easy process or easy way out of this disease. It's very complex. It has a multifactorial which are involved in the outcome of this disease. So it's necessary that we need to understand the signs, the symptoms, and you need to know the history of this when you are diagnosing pododermatitis. It's also common in cats, but it is more seen in dogs when you see in clinical practice. Now, what are the causes? The common causes are infectious, allergies, hormonal, immune-mediated conditions, and tumors. There are a number of other causes also, but I'll be just discussing a gist of all these causes. Now, whenever a dog comes to the clinic, the first thing that you need to see is you need to ask about the history. Before even examination of the dog, I generally ask the history of it, because that gives half of your diagnosis. You need to check, you need to ask whether the dog is licking, whether there is salivary staining, whether there is redness, is the paw bleeding when he is walking, is there biting of the nail, where there is any kind of odor, because sometimes the owner complains that when the dog is sitting next to me, there is a typical odor, and that's not very nice for the owners. Is there sloughing of the pads or nails? Are there lumps? And is the dog limping? Now, this is a short video, so sometimes you do not get the complete history. So it's necessary that I ask owners that whenever the dog is licking or whenever the dog, just send a video, share a video to me. So this is the video that he has shared with me. You can see how he's trying to lick, how he's trying to bite at the paw pads. But here it's more than the pads, it's the interdigital area. You can see that there is complete redness on this part, and you can see how red and inflamed that part of the paw is. All right. And now comes determining the cause or based on the history. First thing is whenever you check that the paws are inflamed, just don't go that the paws are red. No, first I'll check whether it is the foot pad involved. If the head portion is involved, if both is involved, you can see that there is interdigital. In this photograph specifically, you can see that more than the upper part, more than the pads, it is the interdigital area that is completely inflamed. You can even see that there is a small lump around this area and it is bleeding also. Whether the dog is having pruritic or it is just that it is salivary staining of that. What age or onset of that, itching started? What is the environment of the dog? Whether the dog is outside, whether the dog is kept inside the house, what is his diet? And that is a very major, question that you need to ask. And yes, you need to see whether it's seasonal or versus non-seasonal. Now, what are the clinical signs? First is the salivary staining on the paws. You can see that there is erythema, and sometimes it is limited to the plantar surfaces also. That means this part which I'm talking about, that's the plantar surface, and you can see that there is erythema, but only on the plantar surface. Sometimes you can see that there is a nodule, and these nodules are important in diagnosis because generally whenever I see a nodule, I make sure that I squeeze it and I let the initial part be drained, and then I take an impression smear for the cytology of the this. I can also take that sample for antibiotic culture sensitivity test. You can see that there is interdigital furunculosis, hair loss is there, scales are there, sometimes there are abnormal nails. You can see that there is, in this photograph, you can see that there is paronychia. That means there is a brownish discoloration at the base of the nail. You can also see in this photograph, it's not so clear, but you can see that there is a little bit of debris. Now, whenever there's such kind of debris, I'll be discussing that later on, but if I see a debris, I make sure that I take it with a toothpick on a slide to check for malassezia. There is severe pododermatitis and nodular lesions on the dorsum of the paw. How to rule in or rule out depending on the clinical presentation, whether the only interdigital area is involved, whether only pads are involved, whether both are involved, and whether claws are involved. In claws also, you need to see whether single or multiple. Now I'm going to talk about dogs, but claws, whether single or multiple, is important in case of cats. And I'll not be discussing that more about cats or anything, but it's an important part in FLV and FIV test also. So it's necessary that whether claws are involved, whether single or multiple is involved, you need to check for that. Now, I'm not sure how many practitioners do perform these, but there are certain tests that on a daily basis, on a quick, it doesn't even take 5 to 10 minutes to use these tests on your daily practice, just like a skin scraping. Trichogram is one which is the best part. You just take a pluck of hair, you pluck hair and you check under the microscope. It takes hardly 2 minutes just to see whether any dermatophytes or any demodex is involved. Then cytology is the most important part whenever you're going for pododermatitis, because whether it's plain pyoderma, whether it's malassezia, whether there are, you want to check for deep pyoderma, and if you want to go for sensitivity testing, cytology is an important part. Toothpick method. Now, toothpick method is for malassezia. As I mentioned, I just take a small toothpick. I just check. I pull the skin behind the claw, and I make sure that the debris is just collected on the slide. I make sure I take a impression smear of that, and I check for malassezia. That's an excellent way to check for malassezia. Wood's lamp hardly takes 2 to 3 minutes, and that's a beautiful confirmatory test for Microsporum canis. I'll be showing photographs of that also. Fungal culture and biopsy. Of course, there are blood tests involved, there are thyroid tests involved, but I'm going to talk about a very basic way of handling this in the clinical practice. Now comes the differential diagnosis. Now, the dog comes to your clinic, you check the paws, you ask the history. I generally don't go for the diagnostic test first, I go for differential diagnosis. So in my small page, I write down the differential diagnosis, what all I'm suspecting, depending on the age, depending on the history, depending on the lesions and distribution of lesions that I'm seeking. And then I go for the further test so that I get a clear picture of on how many tests I need to perform, rather than just going randomly of performing XYZ test. I like to go with a differential diagnosis first. Now, these are very basic differential diagnosis. The first is infectious, whether it is bacterial, whether it's fungal, whether it is parasitic like demodex or hookworms. I have not got across any hookworm, fortunately, but demodex, yes, and dermatophytosis and malassezia, yes, that's the number. Although I have considered as one of the differential diagnoses, remember, bacterial and malassezia are always secondary causes. So the rest, all the differential diagnosis which I'm going to discuss are primary causes. But if you find bacterial and malassezia, please don't start the treatment and leave it as it is. You need to know that there has to be some primary cause, or else the pet parent will again come back and say that, ma'am, it's just not working. Doctor, it's not working. And the moment I stop the medicines, it's coming back. And that's because you have not come across the primary cause itself. Allergies is something which is the most important, primary cause for most of these diseases, and that is one is difficult to diagnose, and it is most difficult to find to come to conclusion. So atopic dermatitis, we all know that. Adverse food reaction and contact dermatitis. Flea, yes, in India we are, and we have to have flea allergy dermatitis. We just can't move ahead with that. And seasonal allergies also. Rainy season and the beagles come with seasonal allergies. Immune mediated, that is pemphigus foliaceus. Systemic lupus erythematosus. Now that is seen in old age, and it is seen in German Shepherds specifically. I have seen in my clinic. Vasculitis, adverse cutaneous drug reactions, hypothyroidism, hyperadrenocorticism, sterile interdigital pyogranulomatous pododermatitis, that comes and acquired. We have genetic familial paw pad hyperkeratosis. Metabolic is superficial necrolytic dermatitis. Neoplastic is nail bed squamous cell carcinoma and epitheliotropic lymphoma. Chemicals, because of some chemical irritation, because of any contact with the chemical. and psychogenic is acrylic dermatitis. So these all are, as I said, they are primary, and bacterial malassezia has to be the secondary cause. Now, I will be discussing about the common forms of canine pododermatitis. The most common which we see in the day-to-day practice is deep pyoderma. Of course, deep pyoderma is secondary, but that also as a part I'll be discussing today. Second is dermatophytosis. Third is malassezia dermatitis. Fourth is demodicosis, and fifth is canine atopy. Let's come to deep pyoderma. Now, deep pyoderma means bacteria. Bacteria which involves the derm, the deep derm, the subcuticular tissue, and then the hair follicle is involved, which is called as furunculosis, and hence it is called as deep pyoderma. Remember, it's the secondary infection, as I repeated again, and it is necessary to find the primary cause. So sometimes deep pyoderma can be localized or it can be generalized. Clinical signs you can see on this, as I was just mentioning, you can see a beautiful nodule, and if you just, you just have to squeeze it, there will be exudate, purulent exudate, and that you can take it on a slide. You can use it of antibiotic culture sensitivity. So when it comes to using antibiotics, I make sure that the first 1 or 2 antibiotics I do try. After that, the third antibiotic, I just don't start immediately. I don't go trial. I make sure I do the culture sensitivity, and then I go for a higher antibiotic, because it's necessary to know that what exactly bacteria and which is the best antibiotic to work on it. And you can also see acrylic granulomas and areas of pyotraumatic dermatitis in case of as a manifestation of deep pyoderma. This is a German Shepherd who had deep pyoderma. Unfortunately, I do not have the photograph because this is about 2 years back, and I have this picture. This is after 2 weeks of treatment, so you can imagine how there was an exudate, there was scaling, and there was a lot of damage to the dermis. So treatment and management of deep pyoderma. The first and foremost is antibiotics. Now, systemic antibiotics, I always mention that you need to start the antibiotics. You do not stop in between. In fact, there should be at least 15 days after the clinical improvement. You should continue the antibiotics 15 to 20 days, even beyond the clinical improvement. And because you need to maintain as I said, you need to maintain that level of antibiotics in the plateau stage has to be maintained for a few days, or else if the infection is not completely gone, it can recur back, and that is also responsible for our antibiotic resistance that we are developing right now in the world. So I always love to use an antibiotic culture sensitivity. So if a dog has been treated by 1 or 2 vets before, and already he has been tried on 2 or 3 antibiotics, I would not recommend any starting with another new antibiotic. Just go for culture sensitivity. It takes 3 days and you get the best working antibiotic. You can start with 4% chlorhexidine spray, and I prefer benzoyl peroxide shampoos for the flushing of the follicles. And there are certain things that you can avoid. Is you can, whenever you take the dog outside, you can make sure that he wear shoes so that he can avoid contact with the outdoors. There is washing of the paws on a regular basis. Whenever he goes out for the walk, he comes back, you can wash his paws, and use of soft bedding. Now, this is dermatophytosis. Now, dermatophytosis is also called as fungal infection, and the common fungus we see in our practice is Microsporum and Trichophyton species. Why it is important to discuss about dermatophytosis is because it has an epidemiology value. It is contagious, it is infectious, and it spreads to the humans also. So whenever the dog comes, one question I always ask the pet parent is, when I'm looking at the dog, I look at the owner and I ask that, are you having any kind of lesions on your hands or on your face or on your stomach? Because that's the nice clue to get for dermatophytosis, so you don't have to go for any fungal culture or something. So you will find that there is classic signs, there is circular patch also called as ringworm. So there is classic patch of alopecia. There is severe itching. The dog is continuously itching. There is scaling, and you will find that there is the wound goes in circular radially, where there is healing in the center, and it keeps spreading on the in the peripheral area. So that's a beautiful sign that you see to identify dermatophytosis. Face and limbs are affected more, but it can extend to other parts, because if it has delayed treatment, then of course the other parts of the body will also be affected. So this is a beautiful pic of a small puppy which came to a clinic. So I put this photograph specifically because yes, it's a foot slam. You can see that apple green fluorescence on it. But the funny part is the dog came because there was a alopecia on a tip of the tail. We checked the woods lamp, and we couldn't see that there's fluorescence. So the owner said that we could see that there's glowing, but it was not the classic green. So we thought, owner said, no, I applied some cream. And so we were a little upset that no, then we need to go for further test. And the lamp was in our hand, and suddenly the dog moved and he showed his face to us. There was no patch at all, but we could see that underlying that hair, where there was a patch, and that's why that glow was there. So this is how sometimes it can be diagnosed, late, and already the infection has started. So treatment and management. Treatment and management, the more important part is management in dermatophytosis. I've seen that we start the treatment for dermatophytosis, we start, the dog improves, and then we are not able to take care of the environment. There is no decontamination of the environment, and the dog comes back with a new patch. So it's owner's compliance and explaining the owner how important it is to decontaminate and take care of the surroundings, or the surrounding spores will keep attaching the this. It's very important. So that's why we recommend that you go for explaining the owner how it works. You can start with topical treatment with 2% miconazole and 2% chlorhexidine shampoo and spray. That I start for a small patch, but if it is a generalized form, I like ketoconazole and itraconazole. Itraconazole, I prefer more with 5 mg per kg once a day, and OD, and ketoconazole at 5 to 10 mg per kg OD. So as I said, it's important that you go for environmental decontamination. Otherwise, you're not going to manage it, and the owner keeps complaining, and then they start switching the vets also, because you have not explained them that this is about control and this is about management and not the treatment from our side. This is where you can see the photograph. These all photographs are taken from our clinic itself. So I made sure that I involve only those pics which are in my clinic. This is a Rottweiler, and you can see that there is what I was mentioning to you, that there's classic round lesions, and you can see there is crusting, and there is a thick exudate like which is at the base of the hair. Here you can see that the scaling, there is complete erythema. In the paws, you can see that the lesions have extended to the metatarsal area also. And here you can see that there is blackish, grayish exudate. It is like more of a ash color, the cigarette ash like color. And you can see that you can actually take it with a swab also, and you can examine it also. So here, trichogram is the best method to go, and then you can go for fungal culture. Trichogram gives a pretty good picture for you. This is just day before yesterday. Yesterday, Saturday itself, we found that this dog came with a small patch, and there was no other lesions, but the dog was itching. Now, ideally, if you go for only a topical and antibiotics, it would have not worked, because you can see we just did a woods lamp, and you can see that there is a green fluorescence. Rest, everything was perfectly fine. So we started with the topical therapy. Here we didn't go for a oral therapy. Malassezia. Malassezia means Malassezia pachydermatitis. Now, earlier time it was said that Malassezia was restricted to only the ear canals. But now today with a lot of studies have been performed and they are mentioning that Malassezia is found on the other parts of the body also. So whenever, but they are opportunistic. So whenever the immunity of the dog is compromised, whenever there is a primary cause like atopic or any allergy, there is a breach in the barrier of the skin. These Malassezia, they adhere to the canine corneocytes. They bind to the proteins and the glycoproteins, produce enzyme, and that break down the cells which trigger the typical release of inflammatory mediators, and then you find that the dog is itching. So the classic signs include, you will find there is itching, there is a musty and yeasty odor. If you, it's always better to even smell how it is. You will find that there are scales, you find there are crusting, there is flaky skin around, you can see on this part, there is lichenification. It is very common in pugs that there is lichenification. There is hyperpigmentation, and on this part you can see at the base, you can see that there is hyperpigmentation, and there is recurrent otitis externa, where the discharge is typically dark brown in color. So you can actually take the exudate also, and you can take it, smear it on your slide, and you can check for cytology for Malassezia. Now, when it comes to feet, you will find that there is dark exudate at the base of the nails, which I was mentioning about the toothpick method. You will find that the interdigital areas are also inflamed. There is erythema. You will find there is greasy exudate at that part, and especially at the base of the hair. So whenever you check the hair, you will find that there is a base of exudate at the lower portion. You will find alopecia, and you will find there is skin thickening and scaling. Here you can see that there is otitis externa. This is of the same dog. You can see that there is salivary staining because the dog keeps licking, and this is paronychia. So I did a cytology. This is of a dog, Indi and Indian Pariah, and we made sure that we took a cytology and we were able to see. So you see there are the typical boot-shaped Malassezia organisms on the slide, and this is done at our clinic itself. Now, treatment, I prefer going for topical therapy, and you can use a combination of both if the severity is more. So you can go for topical like miconazole and chlorhexidine, similar like dermatophytosis. Your benzoyl peroxide shampoos and selenium sulfide shampoos work better in case of these. So I like to use a combination of the miconazole and chlorhexidine shampoo and benzoyl peroxide. And oral treatment can go with the same ketoconazole and itraconazole. Now, this is the next topic I'm going to talk about is demodicosis. Now, demodicosis means Demodex canis. It's a parasite which, again, it's present on the it's present naturally, and it is a mite that lives in the hair follicles of the dogs. But whenever there is an immunological disorder, whenever there is a genetic disorder, when there is an immunocompromised state, these Demodex can flourish, and then they proliferate into the hair follicles, which otherwise they are normally present on the biota, and they can cause the demodicosis. You will find there is alopecia, there is erythema, scaling, hair casting. Face and head are the parts, and forelegs are the parts which are first affected. So this is of course taken from a book. And we can see the classic signs where you can see that the patch is there. So in our clinic, we recently found that whenever a dog comes with a small patch, we immediately go for a tape test and we see whether it is Demodex. Many times this happens that you find a small patch, the owner either ignores it or the veterinarian ignores it, considering that he must have heard somewhere there is a small patch, just let it go, you can just apply some mupirocin ointment, it should be okay, and then the infection keeps spreading, and it will be always in patches, and you will never realize that it is Demodex that is taking over the entire body. So whenever you find a small patch, the best way is to take a tape test and immediately check. It takes few minutes and you will be able to identify that there is Demodex. So generalized form occurs if the initial diagnosis goes late. So the treatment is isoxazoline derivatives. You can use topical antibacterial spray and shampoos, and benzoyl peroxide shampoos are the best follicular flushing. The breed dogs, this is a Doberman, the first pick. The second is a Pug Mini, and the third one is a Siberian Husky. Now, these are generalized demodicosis. You can see all these dogs, the paws are completely affected, and we didn't even have to squeeze it. We just took a tape. It was so infected. We just had to do a tape test, and we were able to find a number of demodics. Let's come to the last topic, and that is canine atopy. Now, this topic is important because this is very common. You find that it's extremely pruritic, there is extreme inflammation, and it is genetically predisposed. So, this why it is important to discuss, why it is difficult to diagnose, because there is a complete variation in the clinical presentation. So you will find that the variations may be due to the genetic factors, the extent of lesions, the stage where the dog has come to your clinic, the stage of the disease, the stage of the infection, and whether secondary infection has already involved with the canine atopic dermatitis by the time the dog has come to your clinic, or any other resemblance to any other non-atopic related skin diseases. So clinical signs may include the seasonal, it can include the non-seasonal, and it might include the non-seasonal with seasonal flares too. Pruritus is very important in AD. If you say that the dog is not itching and you diagnose with AD, then something has gone wrong. So pruritus is important, and it is a characteristic sign of AD. Dr. Awale has mentioned the 5F method to identify AD, and that is face, feet, folds, friction sites, and flexure points. These flexure points can extend to the front legs, axilla, and abdomen also can be affected. But these lesions can vary with the breed. And the classic signs are where there is alopecia, there is extreme pruritus, there is scaling. You can see that there are hemorrhagic cracks. So the owner complains that my dog is walking and suddenly it starts bleeding. So you have to think about that point also. You will find that there is salivary staining because there is constant licking of the dog. And that if so owner is saying, my dog is not licking, but you can see that there is salivary staining, that means something, the owner is lying about it. You can find that there is excoriations and lichenification, and as well as there is hyperpigmentation. I'm going to talk about diagnosis here because although I spoke about diagnosis, but we do not have a perfect test for diagnosis of AD. So the only way is history, the only way is physical examination, and you need to rule out all the differentials like fleas, the mites, the pyoderma, the dermatophytosis, malassezia, and all the food allergies also. Only then, after you have ruled out every single check, you go ahead with the AD. So after that also you have to figure out about the Fabre's criteria. Now in our clinic, we do take this seriously because if I've ruled out everything, out of these 8, at least 5 signs should be seen in your dog. And then only you confirm that this is AD. So you rule out everything and then you go with the Fabre's criteria. So affected ear pinna. Remember the pinna margin, which is classic for Sarcoptes, should not be involved. Only the ear pinna should be affected. There is front feet, rare can be seen, but you will always see that the front is more than the hind legs. The age of onset has to be less than 3 years. If your dog is showing symptoms at 4 years, then definitely there is something else and you have to figure out the reason. There has to be chronic and recurrent yeast infections. So owner complains that, my dog has been treated whenever I start with the miconazole and, yeast treatment, he shows improvement and again it comes back, means the primary cause is not removed. So this can be one of the primary causes. Go for corticosteroid responsive pruritus. The dogs are mostly indoors. So if owner says that my dog is inside the house only, then why is he getting these allergies? Because your dog is indoors, so it could be AD. It could be non-affected, and it has non-affected dorsolumbar area. If secondary infection is involved, then yes, you can have that part also affected, but mostly it is non-affected, the lumbar area, the dorsolumbar area. And initial onset, where the owner can say that he used to itch a lot, but there were no skin lesions. So now this is also a sign, or you need to look for it. Now, treatment and management of canine atopy. Remember, canine atopy is a lifelong disease. So if your dog is atopic, definitely you have to explain the owner, you need a compliance with the owner that there is only management. You can treat, but you cannot cure. So you need to manage canine atopy. So you need to go for medication and baths. It's important that, because atopy means allergens. When allergens, so the way to relieve the pruritus is keep giving the dog baths on a regular basis. You need to avoid the allergens if you are able to figure it out, which is a difficult task, I can understand. You need to control the other flare factors. So now already your dog is atopic, you need to take care of the flare factors. So you make sure that he is done spot on. You need to take care of the fleas, you need to take care of food, and you need to take off environmental allergens also. You need to control the secondary infections like malassezia and pyoderma. And last is the food trial. So I never go with a diagnosis of canine atopy unless and until I'm sure about the food trials, and which may take 8 to 16 weeks also. This is the same dog. You can see just what I was mentioning. This is a front paws. You can see the lesions are extensive in the back. Calcification, there is alopecia, and you can see redness, there is erythema around. You can see that there is lesions around the, this gives an example that the dog must be extremely scratching at the base of the, of the face. She must be itching, and there is erythema, and there is all these patches around the base. Now this is the same dog. You can see the video. This is a video which I told the owner to take. You can see how she is itching the part of her vulva. So this does not indicate that she is having any kind of worms. You can see that it's not the anus that she is itching. You can see that she's itching the part of the vulva because there is extreme redness. The groin area, you can see the same groin area is red. There is erythema. Poor girl, yeah. She keeps itching, and the owners are having nightmares with that because she doesn't play and she just wants to do is itching. Sometimes they're embarrassed in front of the guest also. And finally, the treatment. So the treatment means management, and when you're managing, you need to take care of these multimodal approach to the treatment. You need to check whether there is secondary infection. So you start with antimicrobials, start with topical therapy, start with systemic antibiotics. Don't keep trying many antibiotics. Make sure you go with 1 or 2 antibiotics, and then you go further directly antibiotic culture sensitivity. EFEs is considered as, there are certain studies that has been performed, and they say that EFAs do help in case of canine atopy because they kind of help in maintain the barrier of the skin, and they take care of the, prevent the contact of the allergens, since they make the barrier of the skin stronger. I like to use topical moisturizers also. So this, whenever dog goes for walk, I make sure that I tell the owner that you can apply certain topical moisturizers. Of course, you can try wearing the dog with shoes. So you actually trying to control the direct contact with the allergens. But topical moisturizer helps to take care of the scaling. It has a soothing effect also. You can use antihistamines and glucocorticoids, which can be topical and systemic. I like to use the both combination because it helps to some extent, and you can reduce the systemic approach also. Immunosuppressants like cyclosporine, and finally is the food trials. As I said, food trials is something you need patience. You need the owner to be completely in with you. He has to be in continuously touch with you. Otherwise, you're not able to perform. And it's a little difficult because even we have seen that with food trials also, the owner is not able to arrange it, it's not able to manage it, and the dog, we do not get successful food trials. So it's a little difficult. So you need to have a multimodal approach to the treatment. So I just want to mention now that, as I said, pododermatitis is, you, whenever you check, it's just not, do not approach it with checking with the legs. Make sure you look at the whole body. You make sure that you see other lesions also. You see the distribution of the lesions. You make sure that you get the proper history. You do the differential diagnosis. You can perform further tests, and then you start approaching. That becomes a little easier, and it, of course, it is time consuming, but then you at least come to a confirmatory way to handle this, and you need to make sure that you explain the owners in certain cases so that they are also in with you, or else they keep running from one pillar to another pillar, one vet to another vet. All right, thank you so much for listening to me, and I hope I have been able to help you a little bit with my presentation.
Thank you, Dr. Madhavi, for taking us on a journey to pododermatitis. We have actually questions coming up, so I'll start with it.
Sure.
Anyone interested in putting up any questions, please do so. She's available for us to answer us back clinically, wherever you have queries. The first and the prime question which comes is, what should be my routine examination for diagnosing a case of pododermatitis? What should be my first diagnosis, first tentative causative, and how do I proceed in a clinic?
Yeah, so the first thing, as I just mentioned, first thing that comes to you with pododermatitis is history. History taking is very important. Once you take the history, you make sure that you check the other distribution of the lesions. Once you check the distribution lesion, you go ahead with the trichogram and cytology. These are the 2 points I like to go with it to confirm whether it is pyoderma. Of course, it is pyoderma because there has to be inflammation. Unless and that, the owner is not going to come to you. So the fact that he's coming to you itself is mentioning that he is having secondary infection, and that's why he is come to you. But you go for cytology, you go for trichogram. You can check with a Woods lamp because it takes a few seconds for that. You confirm these tests, and then you go ahead with further investigation.
Right. The next question is, what is the probable cost of a Woods lamp, and do you suggest for every dermatological clinic to have a Woods lamp?
Yes. So the cost, unfortunately, we have a little small story in our clinic. We bought 2 Woods lamp, and both didn't work properly. From Amazon, I think I had ordered. It didn't work. So my husband, Dr. Ghansham, he got some parts from somewhere, and then he made the Woods lamp. I can later on sometimes show the photograph. I do not have that because I'm at home. So he made the Woods lamp at clinic, and we are using that. So it's not the classic Woods lamp, it's a Woods lamp. That big it is. So we use that. But yes, it's very important because half of your at least, see, not every, if you use a Woods lamp, every time it's a glow. If there's a glow, definitely it is microsporum. But does not mean that there's no glow means it's not fungal. That you can rule out with fungal culture, but at least your further diagnostic can be avoided if there is a nice green fluorescent color. So you can use a Woods lamp, and it takes hardly 10 minutes because 5 minutes you need to heat the lamp, and then after that you need to just see on the door. You need a nice and room where it is black. You should not have the sunlight, and if you can able to manage that, it takes around 10 minutes maximum.
I said, so you do recommend a Woods lamp for every dermatological clinic?
Yes, yes.
Because there are very few of them keeping it, truly speaking.
Yes.
The next question is, what should be can I start with an antibiotic and an antifungal together? Should I, or should I start with only antifungals if I am sure that it's a fungal, but what should be my treatment?
So if you are sure about fungal, you have checked with the trichogram, if you have checked with the Woods lamp and you are, then definitely you need to start with antifungal. And antibiotics, depending upon if you can see that there is bacterial infection also. For that, you don't need to go for cytology immediately. If you see that there is exudate, there is purulent discharge, yes, you can start with antibiotics and antifungal. But if you have not checked for the Woods lamp, you have not checked for the trichogram, you're not sure about antifungal, first go with antibiotics. Go for the test, because I don't like to go with the umbrella treatment initially. I like to go to the step by step, but it's necessary that you tell the owners that why you're going with step by step instead of studying all the medicines together.
I think with the current dates, it's also important to let the owner know why you are taking this treatment, because otherwise you will feel that you are going routine, but the owner shifted to yet another vet. So Madhavi is very particular in saying that you need to suggest to the owner that why did you did this. So right. So yet another question. You have not talked about terbinafine. So is terbinafine recommended, or can we use it?
Yes, it can be used. I'm not a little fond of it. I'm not using it. I've got good results with itraconazole and ketoconazole. I've started using itraconazole more. So I have not used terbinafine more. Once or twice I used and I was not that happy with the results. So I have not used it. So yes, you can use. There are many vets who use that. And in cats, itraconazole is the one which is licensed. So I like to use in cats only itraconazole.
Right. So in her experience, itraconazole is better than terbinafine. So the remaining, it depends on all of you. Ma'am, the next question says, ma'am, can there be pyoderma along with atopy?
Yes, atopy can cause pyoderma. That's what the whole we had a discussion, because pyoderma has to be secondary. And if it is secondary, that means there has to be a primary cause. Now, your primary cause can be dermatophytosis, it can be demodex, and it can be atopy. So, you are treating pyoderma does not mean that you have treated the cause. You need to understand that it could be atopy.
Right. Should we be using corticosteroids for demodicosis is the next question.
No. Corticosteroids should not be used, but we have seen in some cases where there is excessive itching, and after we have started with the fluoralaner tablets, and still the itching is there, just for 2 to 3 days, you might try using it, but I would like to avoid as much, because here already there is immunosuppression. The immunosuppression itself is the reason for demodicosis. And if you start using corticosteroids at this stage, you're going to cause us further immune suppression, and there's no point in using it. So I would prefer going for bathing. You can use some other soothing agents and but still not prefer for demodex at least. Anything where this immunity is suppressed, try avoiding corticosteroids.
I said some people use 2%, some people use 4% of chlorhexidine. So the question is that, is there a differential? How do we differentiate? Do you have any ideas on that?
No, that's of course 4% is a little stronger, so it helps and more helpful. But you can use 2%. In fact, many times in case of atopic, I use the 2% chlorhexidine plus 2% miconazole, because I've seen that atopic dermatitis can cause pyoderma and malassezia. It can be a mixed infection. So I like to use this combination instead of just using. And we do not have plain chlorhexidine shampoos. So I like the combination of both.
Right. The next question is from Dr. Anupam Mittal. It says, for deep pyoderma, since the patient is to be given long-term therapy, which is your first line of antibiotic of choice from your end, which can be tolerated for 3 weeks or so?
I use clindamycin. That's my first choice. Always I go with clindamycin. So clindamycin, cephalosporins, cephalexin, and amoxicillin. So these are the three which I like to use first. And if it's not improved, I go for the second choice among these three. If by chance I'm not able to get good results, then I go for directly antibiotic culture sensitivity. So these are the three antibiotics itself I like, and I like clindamycin better because for skin it works wonders.
Right. This is Dr. Jacob Matthew from Kerala. He heard that you talked about Apoquil used in atopic dermatitis. So, is it available in India?
I think it's going to be launched soon. If I'm not
Yeah.
wrong, it's going to be launched soon.
It's likely to be available shortly.
Yes, shortly. Yes.
Sorry, it is. Sorry for interruption. It is available now.
Oh, it is available. Okay, okay. I had some samples, but I didn't know about that.
The next question is, what is the tapering dose schedule of cyclosporin?
So for cyclosporin, I don't go with tapering in this way. I try to go with days. So if I'm doing once a day, I make sure that I go with alternate days. After alternate days, if there is improvement, I go with twice a week, followed by once a week, then once in 15 days, and then once a month. This is how I follow that regime.
Okay. You talked about topicals and then you talked about orals antifungals. So, could you just suggest what is your line of treatment? Initially topicals for how many days, and then when do I shift to oral therapy?
Okay, so if I see a single patch or two patches maximum, I make sure I use antibacterial, antifungal shampoo. Again, the miconazole and chlorhexidine shampoo. I make sure that I tell the owner to wash that patch at least every 2 days, and the whole body has to be washed. The bathing should be followed with once a week at least if they are in the localized form. And the spray I use chlorhexidine and miconazole, same combination spray I use twice a day. When I make sure that I tell them to apply, I tell them to apply on the surrounding area. So if it's possible, I try to trim hair on the surrounding at least around 1 centimeter of the diameter extra from that lesion. So that way I like to, that application gets easier. If I feel that it's not working, at least for 1 week, I tell them to wait and see. If there is any new patch, if the dog is still itching, if I can see that there is no improvement, it is still red and it is the patch is increasing in size, then I go for topical oral therapy. And then I start with itrocyanol. But I have seen that when localized, if it is this regime is followed, it works much better.
Right. What are your experiences with lime sulfur for demodicosis?
I have not used lime sulfur. I have read about it, but I have not. Unfortunately, I have not got an experience of this. I have used the Demodex. My classic are using this fluoralenin, and I use the shampooing. I make sure I use the shampoo regime. I use the antibacterial, antifungal shampoo along with the benzoyl peroxide shampoo at a weekly basis, alternatively, and then I go with antibiotics. I generally, if it is a small, and we make sure that we catch Demodex at an early stage. We get the spot, so it's easier to handle, and sometimes we don't need antibiotics for that patch out.
The next question is again on Iconazole. It says that I have used Iconazole for cats, but one infection wherein it after 3 months also Muxlam was showing positive. So, any guidelines on that?
Yes, so because you have not taken care of the surroundings. So now this is where I like to tell the owner, the first and foremost, the cat has come positive for microsporum. It's positive for the woods lamb. You make sure that you ask the owner how many cats are there in the house. If your cat is alone, fair enough. If your cat is not alone, separate the cat from the other cats. It's important that you keep the cat in such a place that you can easily clean the surface area where the cat is kept. You need to wash the cages with bleach with 1:10 solution, 1 part of bleach and 10 parts of water. Of course, the cat has to be separated so that it is completely dry, and then the cat should be transferred. You make sure that you vacuum that space. When you're vacuuming, you make sure you wear the mask, you wear gloves. The spores are inside the bag. So when you're disposing it, it has to be disposed carefully. And you cannot open the bag and you cannot keep roaming with the bag in the open space because those spores will be back in the surrounding. And bathing is important, brushing is important. So only medicines do not work in case of dermatophytosis. You need to make sure if your cat is with you and it's on your bed, then you need to change the bedding material daily. It has to be washed, and when you're washing it in the washing machine, you make sure that you do not mix other clothes with it. So these all care has to be taken. Only then it's going to come okay. And in case of cats, the treatment goes for a longer period of time. So I make sure that I go for pulse therapy. In the sense, I start the treatment for 7 to 8 days. I keep a gap of 7-8 days. Then again I start for 7 days and again gap of 7. In this way, the treatment can last for 45 days also. But I have taken pulses. I stop the treatment in between for 7 days. So that works really well, and you all can try it. Really works well. I've got success rate is very good with this.
Do you suggest formalin foot bath for treatment of pododermatitis?
Yes, I suggest every day. Whenever the dog goes for a walk and comes back, I make sure that I tell the owner to wash the foot with the antibacterial antifungal shampoo. I would like antibacterial, but of course we don't have that combination alone, only single one. So I like that shampoo to be used on a daily, every time he comes for a walk, and drying is important. I strongly believe that that's the way to avoid the allergens being stuck to the surface of the paws.
Right. There are a few questions on steroids and its use in skin infections. As Dr. Madhavi already said, that steroids are to be used only when required. Whenever the immune is suppressed, please do not use steroids. Because the next question comes, can I use steroid and cyclosporin together for atopic dermatitis? So over to you. I have just said it broadly.
In atopic, if you're already using cyclosporin, yes, in the initial, till the cyclosporin concentration has come up, I have used a few days in the sense of around a week or so, I have used, because cyclosporin, the concentration to come into the circulation, it takes some time. So I have used, but I have not used for a long time. Once you have already, you are using cyclosporin where there is already immunosuppression, you're suppressing with the immunity. So with that and steroid condition will go worse. And the fact that you are needing both of it, even after some days, that means your dose is somewhere gone wrong with the cyclosporin. So you make sure that you start with the cyclosporin. You can give for quick relief, you can use it for 2 to 3 days, and then you can shift only to cyclosporins.
Shall I add something to your?
Yes, please. Yes, please, doctor.
Actually, while you talk about the terbinafine, somebody was asking about the terbinafine, how it is being used, whether it is having good result and all. Actually, if you are going to use more than 30 mg per kg body weight only, it will be useful, because that is the dose you have to use. Because recent report says, and also we have done a study on it in dogs and cat. Generally, if it is going to be less than 30 mg per kg body weight, it won't be reaching concentration in the corneocytes. So it may not be giving effect. So we have to use more than 30 mg per kg body weight. Apart from that, we have to use for 4 weeks to 6 weeks. Then only it will be useful. Even any antifungal, even itraconazole we have used for dermatophytes. So in that also, if you are going to use continuously, apart from environmental control, if you are going to give a long 6 weeks use or 4 weeks use minimum, then only you will be having a good result. Apart from that, some other person was asking about the chlorhexidine use, 2% or 4% like that. See, recent research have given whatever the concentration, 2%, 3%, 4%, all are giving a actual equal result. But the thing is, when you are using a higher percentage like 4%, it may go for irritation. So some even some when they compared, some author are expressing that it is having more efficacy in the less percentage, that is 2% or less than 4% like that. So if it is going to be more than 4% means in the higher percentage, they may cause irritation for some dogs or a cat. So that is what they have mentioned. And regarding wood slamp, we have enough wood slamp suppliers here, and we have been giving. See, our in Tamil Nadu, we have given for all the people, even for 5,000 rupees, he is ready to get it. And if anyone is interested, he can always contact, because it is the first line of easy identification of dermatophytes. We'll be thinking we won't have dermatophyte. Only if you are going to use it, you'll be getting good result. Even in dog or cat, it will be very, very useful. So it is better to purchase the wood slamp and keep it with you, so that it will be having a very good useful thing. Then you can confirm with the culture or anything. That is the thing. So that is what we wanted to express. And apart from that, in antibiotic usage, we have to go for first line, second line, that they have, because of this methicillin, the resistance for the antibiotic thing, they have identified what to use first, what to use next, like that. In that, first they have always suggested the cefopodaxim or cephalexin, ampicillin groups as the first choice. Then they will go for other thing, clindamycin and other thing. So in some authors, they are telling even the clindamycin, if you are going to use, there is chance for getting without culture, because there is chance for getting resistance with the aminoglycosides or amino groups of drugs. So either if you are going to use any antibiotic for a DUM or anything, first antibiotic usage should be started with the cephalosporin. Particularly the cefopodaxim or cephalexin is the first choice, and then or ampicillin, then only we'll be going for next choices. So in that, sulfa also there, but sulfa is having a lot of side effects, so we are not using it. So that is the thing I wanted to add. Thank you.
Thank you, sir. The next question again is to Dr. Madhavi, and even Dr. Nagaraj can add on to it. Wood slamp is said to be positive for E. canis only. How do we diagnose other types of dermatophytes, trichophyton and epidermatophyton?
It's only by culture.
Culture,
So
yeah.
even for wood slamp, you cannot expect all the 100% microsporum will be positive.
Yes.
Only 60% of the cases will be positive, apple green fluorescence. That too, we have to take precautions, whether it has got any other staining like tincture iodine, anything has been applied before, it will give false positive. So
False
those
positive.
things, that's why we are going for confirming with the culture. So we have to necessarily, but wood slamp is the easy way to identify in our practice. So it is always better to keep a wood slamp, and you go ahead with your confidence. So, and the owner will be very much enjoyable with the seeing all the things, so that they be having some idea the doctor is helping to trying to identify something, and telling like that, they will have confidence on you. That is very, very important.
So I'll just add, every glow, if it's glowing, that's 100% microsporum. But if it's not glowing, does not mean that it is 100% negative. That means it can be positive and negative both. So then fungal culture is the best way to identify.
Right. The next question, and probably the final question, is I'll say thank you to Dr. Madhavi, number one, because she made the lectures short so that clinical questions can come in more. What to do if fungal lesions are reoccurring even after a complete dose of a treatment? This is a very regular problem which every vet faces. So Over to you, Dr. Madhavi.
Yes. So the same thing as I repeated, I like to make sure that I keep telling the owner that right from the belt the dog is wearing to the bedding material has to be changed. I tell the owner to that. I make sure that I tell him to brush daily. Whenever he is brushing, it has to be brushed in a proper place where it's not too windy. If he's doing in a controlled area like bathroom, so that the spores or whatever it's not infecting in the surrounding. I prefer his bathing, so he can use the same shampoo throughout, the same antibacterial, antifungal shampoo. I tell, even after the recovery is there, I do not switch on to the next shampoo. I make sure that I tell the owner to keep the same shampoo. I continue the same shampoo for a little. There also the baths, I prefer going once a week. And unless and until it's more than a month and he's not recurred, or 2 months is not recurred, then I go for once in 15 days bath. Otherwise, once a week bath is compulsory. And the food also, I prefer. There are certain studies in humans which I was reading recently, where if it's a fungal, this research paper was there where they mentioned that if it's fungal infection, please go for less starch and more proteins. So, as per them, trichophyton specially lives on the starch. So, if you can avoid starch or you can reduce the starch content from the food, that also helps to some extent. So, this is actually an article which one of my client gave me to read, and I really loved that article, and I started taking that as a suggestion while going for the next treatment. And I make sure that I keep, if it's a long haired dog, I tell them to clip the hair, especially the one which is close to the abdomen, so that whenever he is sitting, whenever he is having the contact with the surface, it can be reduced with the attachment of the spores to the keratin of the hair. So that is one way to handle it.
Right. Madhavi, the last question. I think many times I am becoming a barrier. If the question comes to me, ma'am, why do we have this? It seems that I am a barrier in that. So I'll put the last question, which says, ma'am, why do we have to go for antifungal pulse therapy in cats and not in dogs?
No, so in dogs also we do get. Cats, I have the fact that to take the antifungal in cats, they are a little sensitive. So I prefer going for pulse. In dogs also, if it's long term, I do go for pulse therapy, but I do not go for a weekly therapy. Here I have done it is 2 days at a time. In a week, I have stopped the medication. So for example, if I'm going from Monday to Sunday, I make sure that Wednesday and Thursday probably I don't give the medication. So I do go for pulse therapy in dogs also, if I'm keeping the dog for a longer duration. And in cats, because they are a little sensitive, then of course you're going with antifungal medicines. The liver is values have to be checked on a monthly basis, or sometimes in 3 weeks also. So in cats also I do, and in dogs also. But dogs I generally didn't require more than a month. But if I have gone for a longer duration, I have gone for this therapy. If it's an old dog also, I go for the pulse therapy. I have not done the weekly, I have done this 2 days at a time.
I think that brings us to the end of the session. I thank Dr. Madhavi Awale for taking us on a insight into pododermatitis, its diagnosis and management in the entire canine sector. So, Dr. Nagaraj, if you want to sum up, or we can do that.
Yes, he has done nicely. Good presentation. Thank you, doctor, for your presentation.
Thank you. It's my honor that you all called me. I thank Dr. Nagarajan. I thank Dr. Nitin also. And thank you, Intas, for giving me this opportunity to talk on this platform. It's an honor that you all called me for this. And I'm really happy that I'm a part of it now.
Thank you, madam. Thank you to the entire audience. I'll request you to keep watching us for the next webinar. We'll try to bring in more matters of concern and more matters of clinical importance. Thank you.